This is my first experience giving such an online lecture, so please pardon me if there are any basically glitches or small, I would say, technical hiccups while presenting this. As Dr. Khan kindly introduced me, and he's also explained that I'm going to present on interventional radiology. Now, interventional radiology itself is a very specialized subject, and normally the examiners should not ask you any questions into subspecialty, especially any deep questions about interventional radiology. But having said that, there are certain cases or there are certain diseases which once diagnosed, they tend to ask the question related to management, and the related management normally involves a little bit of interventional radiology. Also, some cases are shown, which I'll show you the similar circumstances over here. Some cases are shown which, if you don't have any experience in interventional radiology, you will not know that what's exactly being shown. And in the examination situation, what happens is if you don't know anything, you get stuck onto that, and that basically stays in your mind till the time the whole examination is over, and that can basically shatter your confidence. The whole purpose of today's session is basically to familiarize all of you with certain conditions which can basically pop up in the exam, and also to make you aware of it. Okay, a moment. Okay. Now, as explained, we'll be just giving you some insight about the interventional radiology procedures and management. Also, we'll be revising some interventional radiology exam cases during this session. I'll appraise you about common procedures as well, because at times the candidates are asked questions, how are you going to perform this? So just to give you a brief insight on how the different interventional radiology procedures are performed. Also, I'll emphasize certain key points in interventional radiology, and occasionally I'll be also revising some common anatomy. Although if you go into too much depth, that will be, I think, will be counterproductive for the length of this presentation. Okay. So this is normally the first slide which I show to my one-to-one teaching. This is not for candidate one, this is for everyone. And just to basically appraise you the situation, that eyes don't see what the mind doesn't know. Okay? Or mind doesn't see what eyes don't see what the mind doesn't know. And in this basically slide, I normally ask the candidates if they can spot a cat during all this clutter. I'll give you just briefly about 10 seconds. And it's basically for you to self-assess that how many of you can spot a cat in all this clutter. In exam situation, everyone is under stress. Once the films pop up or the slides are shown or the basically presentation is given in front of you, everyone is under stress to find the abnormality as soon as possible so that they can answer it accurately and move forward. But just to appraise your situation, now I have highlighted where the cat is. So now you see it is much easier to spot the cat. So even if you see this slide next time, your eyes will quickly go into the area where the cat is. That in exam, this is the whole emphasis of my presentation today, that to show you the certain things about interventional radiology and appraise you so that next time you see any such similar case, you are quick to answer and take it from there on. So candidate one, here is the first case for you. Kindly describe the examination which is being performed and describe the findings. Candidate one, sorry?
Can you hear me? So this is still images from an ultrasound examination of the thyroid gland, and there is a nodule within the right lobe of thyroid, which is part solid, part cystic. It doesn't show any obvious calcifications on the included images, and there's no Doppler interrogation of it. Other than that, it's quite well defined but heterogeneous. There's not really any posterior acoustic enhancement or shadowing to speak of.
Good.
The overall evaluation of the nodule would likely be indeterminate, and I might recommend a fine needle aspiration for cytology.
Okay. Now, just to add further, you have described it very well. I mean, normally the first two images which I've shown you in the previous slide, that is enough to describe, as you said, indeterminate. But are you aware of any classification system and how to classify the thyroid nodules?
There is an ultrasound grading system from U1 to 5, I believe, but I'm not very certain about exactly what would make a nodule change between each category.
Good. So before the exam, it would be good to familiarize yourself at least to some broad spectrum parameters which are used in grading such thyroid nodules. Because once you're describing it, it is also paramount to then comment that which nodules are you going to do the aspiration, which nodules you can clearly say that those are benign. Okay. This system was basically first presented by British Society of Thyroid, and it was published back in 2014 in Clinical Endocrinology, and I'm sure you can search for that on the internet, and then can go to the guidelines. And in the same paper, they have basically given a guideline that how one should describe the different thyroid nodules. For example, as you rightly said, it appears as solid or cystic. You define its position, you define its parameters like the Doppler signal, also about the calcification you have made a comment. The other thing, normally it is commented where there is any capsule or any curvilinear calcification, color flow, and then classification. Okay. About the classification, again, in the same article, they have given visual representation as well, although there's a long description in the article about that. What I showed you, that is basically a hyperechoic nodule, which was diffused hyperechoic throughout. It had only very slightly irregular margin and very slightly irregular capsule. And as you rightly said, it is indeterminate or U4. Indeterminate basically starts from U3. U5 is obviously malignant, and I mean, as one can say, if it is hypervascular, it has got microcalcification, and as it is longer than wider, then yes, that points to the malignancy. But on the similar, I mean, I'm sure the head and neck session will cover that as well. With regards to the same, there's a further publication which came in 2017 by a European Thyroid Association called EU Thyroids, basically thyroid imaging and reporting and a data system. And they have used the similar characteristics as published by the British Society, but they also include that they have also included the size of the nodules in addition to all the features, and then they describe between the medium, moderate, or high risk, and then basically suggest what needs to be done and whether FRCR needs to be done. Now, once you have described everything, normally the next question is, if you say the aspiration, how do you perform the aspiration? Can you please describe how would you do the aspiration of this nodule?
So I performed the aspiration under ultrasound guidance using a small caliber hollow needle, which I would pass through the lesion and agitate to take a fine needle aspiration, which I would then spread on up to three slides for pathological analysis.
Good.
Depending on the patient, I might offer local anesthetic, although it's quite a fine needle, and in many scenarios, local anesthetic is not necessarily needed for tolerance of the procedure.
Well, it all depends from patient to patient. One may not need a local anesthetic. On the other hand, if the location is such and patient is agitated, then you may need local anesthetic. You have described the fine needle aspiration really well. Now, normally, I mean, in my practice, I normally use a 23 gauge needle. Some practitioners, they recommend using a short spinal needle because they say once they have passed the hollow needle into the target nodule, spreading onto the slide is easier by pushing the stellate of the spinal needle through the spinal needle and then get spreaded. 4 to 6 slides. Some are air dried, some are fixed, but it all depends on the local policy of the department and local histopathology lab. Okay. Normally, you also need to describe that there will be some saline wash, i.e., you will wash the needle with saline, and that saline wash also for the histological or cytological analysis. Now, based on the same theme, just basically expanding onto that, how would you describe this examination, the slides shown in front of you?
So again, I'm presented.
These are slides of a different patient, and this is not thyroid, but next to thyroid.
Okay. So again, I'm presented with selected still images from an ultrasound examination of the superficial tissues. There is a nodular soft tissue abnormality, which on the measurements in the top left can be seen to be taller than wide. Oh, so, well, actually, I'm not sure that's true. In a different axis, it's wider than tall. So I think it is actually wider than tall overall. It shows some vascularity at a point at the mid-inferior part of it. And that area is slightly more hyperechoic. The overall appearances are that of, this looks like a lymph node.
Good.
Size is larger than would be expected, I think, in any anatomical location. The requirement for further action in the form of biopsy, I think, would have to depend on the clinical context. If there's a good reason to have enlarged lymph nodes, such as active infection in the area and so on, you might choose to monitor. However, the morphology of the lymph node is abnormal. It's ovoid in shape, and the cortex is not well defined, with quite a lot of heterogeneity in that area.
You described it very well. Okay. The only thing which I would like to add is that once you have identified that this is the lymph node, the next thing ideally you should comment whether it is still retaining its platyhylum or not. Okay.
Yep.
Because as you know, that the reactive lymph nodes tend to retain their platyhylum, and all those lymph nodes which are involved in metastatic process or slightly malignant process, they tend to lose their platyhylum fairly early. Now, suppose this lymph node had retained the platyhylum, how would you have done the FNA? Which area would you have targeted?
I would target the cortex, so the more hypoechoic area around the periphery.
Very good. So the hyperechoic area is usually the central medulla, which contains the fat and the vessels. That is usually scanty in information. So once we are targeting the lymph nodes, especially for the FNA, it is important to describe that you're just going to target the cortex of the lymph node, and the rest of the procedure remains the same as for the FNA thyroid you described. Okay. Now, going to the next slide, how would you describe the findings in this slide?
So we've put a single still image from an ultrasound examination, which demonstrates a nodule in what's labeled as the parotid gland within the substance of the gland in what appears to be the superficial lobe of parotid. There is a well circumscribed, generally hypoechoic nodule with some internal heterogeneity in terms of echogenicity, and no obvious vascularity on this single image that has a color box applied. There are also axial and coronal MR T2 weighted sequences through this nodule, which show it to be of fairly uniform low to ISO intensity on T2 weighted imaging.
Good. Now, what would be your differential? How would you present it that this is likely to represent what?
So the appearances are of a primary neoplasm of the parotid, which does not have, on these selected images and modalities, it doesn't have, frankly, malignant features in that it's well circumscribed. There's not a large solid component, I'd like to assess for enhancement, as I presume the MRI scan may have post-CAD. But it might be a low-grade neoplasm. Differentials include lymph node, although the morphology is not suggestive of that, or a metastatic deposit from elsewhere.
Okay. So, I mean, whenever we're describing the parotid gland, as you said, very rightly said, the glandular lymph nodes is one of the common findings. But having a look at this, I mean, this appears to be fairly related to the parotid gland. Okay. Pleomorphic adenomas or pleomorphic carcinomas, I mean, in the adenocarcinomas within the parotid gland, that is our concern. And again, FNA or core biopsy is offered. What would you do in such circumstance? Would you do an FNA or a core biopsy?
I've not personally had much clinical experience with it, but a core biopsy in general offers more tissue for analysis. And given that this lesion doesn't have prominent vascularity, and we can see from the MRI that it's not got flow voids or anything like that, I wouldn't be too worried about hemorrhage risk with the larger needle.
Good.
So I'd probably offer a core biopsy in this instance.
Good. Now, are you aware of any specific complication associated with core biopsy of the parotid gland?
I suppose, I mean, there are the complications associated with biopsy in any case of any target organ infection, bleeding, pain. I don't know whether you can get sort of sialadenitis secondary to biopsy.
Well, I mean, infection is one of the complications, but what I wanted to know, or the examiner may want to know, it used to be a great fear amongst all those who used to do the biopsies of the parotid gland that one can create a salivary fistula, because parotid gland with salivary enzymes, there used to be a great concern that it may lead to basically cutaneous fistula, and every time the patient is then chewing and basically excreting some saliva from the site of the exit. Having said that, now, I mean, based on that, previously it used to be recommended that one must not do a core biopsy of the parotid gland unless absolutely necessary. But the recent studies and publications have suggested that actually that fear is basically unbased, and one can easily perform a core biopsy of the parotid gland, and the risk of the salivary fistula is extremely small. As you said, Wilma, I mean, the core biopsy needle basically offers more diagnostic information, so that should be ideally the first choice. And that is usually offered now, although smaller size gauge needle is used. Okay. Now, when we use the core biopsy needles, the usual answer to that is, even in thyroid, one can use the core biopsy needle. The lymph node is generally the core biopsy needle which is used. Also, I mean, if the FNSC or repeated FNSC has become negative, or if there is a suspicion of lymphoma, then one must always use a core biopsy. The reason for that is, in order to diagnose the lymphoma, histopathologists, they need to see certain number of basically lymph follicles before they can make a diagnosis. And that information is not available in the fine needle aspiration. So it's better to perform the core biopsy in such cases. Okay, I'll take you to the next case. Okay, chest X-ray has been presented. Can you describe your findings?
This is a frontal chest radiograph of an adult patient. There are multiple bilateral airspace opacities, which especially in the right chest appear to represent nodules or masses with spiculated borders. And on the left, there's a more ill-defined mid-zone opacity. I don't see any obvious mediastinal enlargement to suggest lymph nodes, but nevertheless, my next step would be to perform cross-sectional imaging to assess this for either primary or secondary malignancy.
Good. This is the next investigation done for you.
So again, demonstrate. So what we've got are soft tissue and lung windowed CT reconstructions through the chest. And there are right-sided pulmonary nodules with irregular borders, some of which show some cavitation or low density within. I'd like to, if I had the imaging, the study in front of me, I'd trace and check that these weren't air bronchograms. And then lower down in the chest, there are more confluent areas of either solid soft tissue or consolidation.
Okay.
But, yeah.
Okay. There is some other additional finding.
So, for example, just looking at the parenchyma and the interstitium on the left in the lower slice, there's some interlobular septal thickening, which, if I suspect that the appearances do continue to represent malignancy, might represent lymphangitis carcinomatosis.
Yeah, that's a good observation. Kindly have a look in the paratracheal region.
So there's a right hilar lymph node, which of course I've measured, but looks a bit prominent. There's also another lymph node anterior to the trachea, and on subcarinal as well.
Good. So, can you now summarize your findings?
So the appearances are of bilateral pulmonary malignancy with mediastinal lymph nodes. There is apparent pleural involvement, and there is involvement of at least both lungs. So this would be a relatively high-stage tumour. I think T4, but I'd have to check the TNM classification for the likely malignancy.
Okay. Now, the only thing which I would like to point out, I mean, you have identified the lymph nodes very well there and prominent, although not made, likely to be enlarged. But if you look at the paratracheal lymph node, that is still retaining its fatty hilum. Okay. So, although, I mean, that alone lymph node can be reactive because there are other enlarged lymph nodes as well, and the malignancy should be high on our suspicion. So, once you are describing this case, what would you describe to the examiner, but how you can help this patient further?
So, although malignancy is probably the number one differential one that has to be excluded, this could still represent multifocal dense consolidation within the lung from an inflammatory process. And one way to help determine would be to establish whether the visualized enlarged lymph nodes contain malignant tissue through potentially an endobronchial ultrasound biopsy. The deposits within the chest, within the lung itself, also look amenable to a percutaneous biopsy if that was desired.
Good. Now, when you say percutaneous biopsy, which modality are you likely to choose?
I would perform that under CT guidance.
Good. I mean, normally, these are the basically large consolidation areas. Malignancy, alveolar cell carcinoma, they can be sheet-like and they can appear to be bilateral on their presentation. Okay. Now, the CT is the usual modality of choice because we have very small areas when we are targeting it. But in this case, or the other cases which you may see in your practice, if there is a large tumor, large lesion, especially the subpleural ones, you can also do all those biopsies under ultrasound guidance as well. Now, what are the considerations when you are going for the CT-guided lung biopsy?
So the patient has to be able to lie flat within the scanner. It's not a very long procedure, but potentially for 10 or 15 minutes. They have to have an adequate respiratory reserve because one of the most common and most likely complications is a pneumothorax. So they may potentially temporarily lose the function of one of their lungs. And then there's, again, all the usual questions regarding a biopsy in terms of bleeding risk. Do they have normal coagulation, etc.? And as you mentioned, the accessibility and suitability of the lesions. So some might be very central and near great vessels, might be difficult to target, or you might find other chest structures are in the way.
Good, absolutely right. I mean, you described it very well. The only thing which I would like to add to your description is that you must recommend that all these patients ideally should go through a respiratory MDT. The reason for that recommendation is that full respiratory assessment is needed, especially, as you said, regarding the lung reserves. Are you aware of any guidelines?
I'm not aware of specific guidelines in this context.
Okay. Would you sedate this patient?
I would hope to avoid it, because obviously any level of anesthesia, even sedation, has complications, and in most cases, this biopsy could be performed without sedation. It is potentially an option if the patient is very claustrophobic or very needle phobic, but it's still felt to be essential to get the tissue.
Very good. So just to recap, or just to basically summarize things again, that you choose the patient based on the imaging. The patient for the lung biopsy needs to be discussed in the lung MTT. It has to be assessed by the respiratory consultant that patient has got adequate lung reserve, okay? And then you position the patient accordingly and then perform the procedure. In terms of guidelines, British Thoracic Society did publish the guidelines back in 2003. These are still valid. I mean, they have not been basically overruled yet, I mean, despite 17 years. So they're fairly comprehensive. I've just put some salient points over there. As you described, there is one dreaded complication from the lung biopsies is the pneumothorax. Basically, 60% of the patients going through the lung biopsy will have some sort of pneumothorax. Only 5% of them will need some chest intubation. So one can basically describe that when discussing with the examiner. Also, important to document and mention is that there is incidence of the late pneumothorax once you perform the lung biopsy, and the examiner can ask you whether you do any subsequent imaging. Answer to that is yes. It is usually a chest X-ray, which is performed 1 hour after the procedure, although we send the patients home with the warning that the delayed pneumothorax can happen even later, and they may have to come back to the hospital for the same. Okay. Now, this patient basically have had fibrotic change secondary rheumatic disease, and this is patient's X-ray after the steroid therapy, so it was not a malignancy. Okay, that is just to highlight that what is the importance of the biopsy to manage the patient. Okay. Next case for you as well. Kindly describe the findings, basically describe the findings on the images presented.
So we have axial contrast-enhanced CT images through the upper abdomen. In the liver, most predominantly affecting the left lobe, there are multiple discrete low attenuation areas, which I would measure if I had the study in a PAC system, as well as a further large lesion, which is inferior to the liver in the region of the gastrohepatic ligament. I'm not quite sure whether this is within the mesentery or perhaps related to the pancreas or small bowel or another nearby structure. I'd have to look above and below and evaluate that. But looking at the multiple liver lesions themselves, if they're not cysts, and I don't think they're simple cysts, the walls look slightly irregular and there's some minimal enhancement. My differential for these is between either cystic metastases from malignancy or abscess. I would want to evaluate the clinical presentation of the patient. If this patient has presented septic with fever, I suspect these might represent hepatic abscesses, multifocal.
I mean, you're entitled to ask examiner questions that whether this is, I mean, the patient has presented septic or not, because then that will narrow down your differential. But you can also ask the examiner whether there was any previous imaging. So here is some previous imaging. Have a look at this. Okay. And now this is the current imaging. So what would be your differential?
Okay.
You want to have a look at the previous imaging again?
Yes, please.
Sorry. this is the previous imaging.
Okay, so the patient already had multiple hepatic cysts, and they look quite simple on those images. And now there are new lesions that weren't previously seen, which, as I said before, are generally low density, a little bit irregular around the edges. My primary differential remains that these have acquired newly since the previous imaging. They're not benign, but they could be infectious/inflammatory or malignant.
Good. I mean, the patient basically presented with just abdominal pain and sepsis. So I think that would go with your initial differential that is likely to be infective collection or liver abscess. Now, once you come to that conclusion with the examiner, usually the next question would be, can radiology help in such situation? So how radiology can help in such situation?
So it's perfectly plausible to place a percutaneous drain into one or more of these. I would mention that they are multilocular and in fact look almost separate. And so draining one part is no guarantee that you'll be able to drain the whole, but it might help.
Good. Now, the examiners then normally ask, can you please describe how do you perform the drainage?
So just looking at the CT, it looks like these lesions would be accessible through the anterior abdomen. They don't seem to be overlying bowel or other structures, and luckily they're not high up within the right lobe or etc. So I perform the procedure under ultrasound guidance with informed consent from the patient, and after checking that they're suitable in terms of coagulation and similar factors, I would use local anesthetic to numb the skin, and then essentially I have two options. I could either use a single puncture technique or a Seldinger technique, but either way I would access the lesion with a needle and then pass over that a pigtail drain, which I would then aspirate as much pus, if we presume these abscesses, as possible before securing the drain.
Good. You described it very well. It's basically the buzzwords which the examiners would like to listen is that you are going to use Seldinger technique, because what is exactly meant by Seldinger technique? Do you know?
So that technique would essentially indicate the placing of a guide wire to the target position prior to the placing of the final device, in this case the drain, over that guide wire.
Good. So describing the Seldinger technique very well, and normally in interventional radiology, it could be small size drain or large size drain. They can be self-locking, unlocking. Some drains can be sited directly by direct puncture. That is not a Seldinger technique. But in order for the safety, normally it is recommended that for such situation, especially going for the liver tissue, one must use the Seldinger technique to be on the safer side. Now, you have described that you will be checking all the parameters, especially the clotting one. Now, once you are checking the clotting, what you are looking for?
So essentially, I'd expect the team responsible for the patient to have performed basic blood tests, which would include full blood count, where I check that the hemoglobin is adequate and that there isn't thrombocytopenia. So I'd want the platelets probably to be around about 50 at least. And I'd also want to check the INR. Again, thresholds vary, but roughly 1.4 would be seen as an acceptable threshold to perform the procedure. Especially in hepatic disease, it can be a bit difficult because obviously if there's significant dysfunction of the liver, the INR may be raised in any case. But the patient could be given clotting factors pre-procedurally to correct any disturbance.
Good. And I mean, you described very well there, especially the value of INR. Most centers, I mean, it is between 1.4 to 1.5. Obviously, it depends on the individual preferences. Is there any guideline about the count of the platelets, that below which count you will not perform an interventional procedure?
Again, I'm not certain of a sort of national guidance on that. I think if I was really concerned about the patient, I could always discuss it with my hematology colleagues.
Good. Well, I mean, the hematology colleagues probably may not comment about the interventional procedure, but obviously they can help. But generally, I mean, if you go through the BSIR guidelines or SIS, psychointerventional radiology guidelines, especially for procedures like this one, it is generally recommended that the patient platelet count has to be at least more than 50,000. Less than 50,000 people, they would recommend having patients some platelet transfused before you do any procedure. Okay. So now I'll take you to the next case. So this is a 70-year-old.
Excuse me, Asad. I think time to go for the next candidate.
Okay.
If I can guide you there. Candidate 1, thank you very much. And candidate 2, can you raise your hand, please? We cannot see candidate 2.
Okay.
If candidate 2 is not okay, I can see somebody now.
Yeah.
Oh. Candidate 2, can you speak so that I know that you are hearing us and we can hear you?
Can you hear me?
Yeah, we can hear you.
Loud and clear. Asad, I'm muting myself. Over.
Okay. Thank you for joining us, candidate. I mean, I'm sure you must have been following us. This is our next case. This is a 70 years old who presented with abdominal pain. Okay. I'm just going to take you some images. Okay. So here are the images. Can you please describe the findings?
So these are selective axial slices through the lower abdomen, scan, which is demonstrating the right colon, probably cecum as well, and there's a collection around the right colon / cecum. Obviously, I'll have to go through the level once I scroll them down. So there's a collection with the peripheral enhancing border or wall. There's also surrounding adjacent inflammatory stranding in the mesentery. I cannot see any free gas in these slices or extraliminal gas. However, there are a few small tiny locules of of gas within the collection. For example, on the top right side of the screen, or top left side of the screen, yeah, right and left. So these are in keeping with the pericecal or pericolonic collection, likely infective.
Right. Okay, so you described the findings very well. There is a lot of stranding. There is obviously some fluid. You have described about the air. It's likely to be infective. This was a perforated diverticular abscess. Okay. Now, one of the questions which have been asked from the previous candidates, which one of these would you treat? Which one of these would you like to drain? And which one of such collections ideally should be dealt by the surgery? Are you aware of any guidelines?
I'm not aware of any guidelines as such, but this is quite a large collection, and surgeons sometimes they try to treat conservatively before the patient is septic, and they normally ask interventional radiologists to drain if they are drainable. Especially the one which is in the right flank seems to be quite accessible through CT guidance.
Good. I mean, this one is fairly large, as you rightly said, and it is amenable to percutaneous drainage. But at times, these collections can be fairly deep in the pelvis, and they may not be amenable to direct access or easily accessible. Okay. However, one of the previous candidates has given us a feedback that some examiners, they are looking for a Hinchey classification of such drainages. Okay. I put the slide over there. So basically, this classification describes about the abscess according to their size and whether they are walled off or not. 1 and 2, stage 1 and 2, better off with interventional guided drainage. Stage 3 and 4, they are better with the surgical drainage. Okay. The other consideration is the size of the abscess or the size of the collection. If it is less than 3 centimeter, it may not need drainage. It may just need some antibiotic cover, and it's likely to get better with the conservative management. Also, the patient's comorbidity is also defined. I mean, it is a stage 3, basically generalized purulent peritonitis has happened. But on the other hand, the patient has got so many comorbidities that giving a GA to the patient might be detrimental. In that case, the interventional radiology comes to fore, and basically you need image-guided drainage. Drainage as described by the previous candidate, cellular technique, drain size. Okay, so those are things which they would like to know. They tend to ask the examiner tend to ask the questions. Okay.
Yeah.
Now, this is a slide basically describing the technique. In this case, cellular technique under CT guidance. One goes for the shortest possible route towards the collection and can basically put a pigtailed catheter of appropriate size. Okay. So the next case for you is a 74-year-old male who 4 years ago had been diagnosed with adenocarcinoma rectum. And I'm showing you a surveillance scan. Okay?
Okay.
Can you please describe the findings on this examination?
These are selective axial CT scan slices through the liver and upper abdomen, especially through the liver, which is demonstrating a geographical irregular shaped, few geographical irregular shaped lesions, hypoactivated lesions within the liver, mainly predominantly in the right lobe. There also, I cannot see any vascularity. Obviously, it's a portal venous or delayed phase scan. However, I cannot see any vessels traversing through the large irregular shaped hypoactivated lesion in the liver. On top left slice, there is a vessel, it's probably in the normal liver parenchyma. However, so these are quite suspicious looking lesions. I would definitely compare with the previous imaging, since the patient has had a carcinoma of the liver, a carcinoma of the rectum, so there must be previous imaging. Previous imaging confirms that these are new. Good. And in the context of the disease previously, these could either represent recurrence with the secondaries in the liver, secondary metastasis in the liver, or this could again be some unknown primary with the metastasis in the liver. These are my top differentials considering the age of the patient. If they're septic, then these could also represent liver abscesses.
Good. Now, so there's a wide differential now you presented. It could be metastasis, it could be another primary, and liver abscess. The patient basically presented being just grossly unwell. Now, what would you do? How would you suggest how to differentiate between these three?
So MRI, we can do either triple phase liver CT or MRI of the liver with contrast and DWI. And I would be keen to have contrast in the early arterial, late arterial, and the delayed phase as well to characterize it. So these are the slices through selective slices through axial sequence through the MRIs through the liver.
Good.
Is so top left of the screen is the T2 as a label here, T2. Normal weighted and heavily weighted T2, which is demonstrating hyper intense, irregular, hyper intense signal intensity in the area of concern. While DWI B1000 and ADC is again demonstrating no restriction, no different restriction.
Good.
So abscesses normally restrict.
Well, they can be non-restricting as well.
I would like to know if there is a contrast sequence done that will help me further characterize.
I mean, not available at this moment. No.
On the basis of these, so non-restricted lesions which are hyperintense on T2.
Okay.
These could be liver abscess.
Okay. Describe the findings. I mean, I have presented another slide for you.
So it's an ultrasound, it's a slice through the ultrasound examination of the right lobe of liver, which is demonstrating a heterogeneous echogenicity lesion, which is irregular shaped. Yeah.
Very good. Like, I mean, it's a heterogeneous echo texture. You can see areas of low echogenicity. There is some post-echoic enhancement. So probably some fluid-like situation. But having said that, it is much different from the initial presentation, okay? Which looked diffusely hypo-attenuating on the CT. So basically this patient, I mean, you have very rightly pointed out about the three differentials, but when it's presented to us, it was discussed in the NDT, and the concern was that as the patient is unwell, it could be a liver abscess, because previously the patient did not have anything, okay? So the patient went on to have an ultrasound to drain the liver abscesses, but actually nothing was found, okay? So we found out this MRI afterwards, which is showing a sheet-like pattern. Now, the only thing now to resolve is basically to the diagnosis was to perform a liver biopsy, okay? Which we have recommended previously, that if it is a new primary or metastasis, liver biopsy can settle the score that which one is the diagnosis. Now, can you describe the technique of liver biopsy, how the liver biopsy is performed?
Yeah, so it's performed under the ultrasound guidance.
Good.
And obviously, pre-biopsy checks, as a previous candidate, and you have mentioned earlier, as normal blood checks, PT, platelets, hemoglobin level, cross-matching, all these needs to be done. Consenting needs to be done. And then the technique is ultrasound guided through, it varies from center to center. In my center, we do with the argon needle, 18 gauge needle, and percutaneous biopsy. Normally, we try to avoid the lesions which are reaching out to the capsule. We try to find a lesion which has got an intervening normal liver parenchyma.
Why is that important?
Bleeding, because once you go through the capsular lesion, then there's a more chance of bleeding.
Well, I mean, you described it very well. The reason we tend to put some normal tissue to avoid the bleeding, okay, because the diseased liver tissue, I mean, its clotting is disturbed and it does not have the normal cells. So the risk of bleeding is greater. So we tend to keep a cushion of normal tissue. Initially, you said ultrasound guidance. We can always use this ultrasound as a first choice, but we can use the CT as well to guide our needle into appropriate area. Okay. So once the examiner asks, you can describe the technique. Also, the one thing which I tend to recommend is that we must, in addition to having a normal tissue, in order to perform a procedure safely, we must also try to give local anesthetic within the liver capsule, because otherwise these procedures, they become very painful. So we tend to infiltrate the liver capsule as well. That should be highlighted. Also, one need to highlight that the patient needs to be in the consenting procedure, that some pain is likely, especially the pain radiating to the shoulder, because the patients, if they are unaware of it, they can be caught off guard and they can complain afterwards, okay? Clotting status we have already commented. The technique you already described. Coaxial technique is usually the method of choice. We can use 16 or 18 gauge needle. It all depends on the local choice. Okay. So the next case coming for you is a 48 years old male presenting with abdominal discomfort and swelling. Here are the findings, the ultrasound images. Can you describe the findings?
So these are selective slices of ultrasonic scan, transabdominal ultrasonic scan to the liver. So liver has got slightly cirrhotic or nodular margin. And nodular margin. Its parenchyma is showing the same echogenicity as the adjacent kidney, so I wouldn't call it. So it's iso kind of echoic, which is good. There is a lesion in the right lobe of liver, in the top right slide, top left side of the screen, with posterior acoustic shadow. I'm not sure what it's representing. It's whether it's within the liver or whether they're. It appears to be in the liver parenchyma.
It's nothing. It's
okay.
It's a shadowing.
Okay.
To the vessel.
In the kidney, there is also. I don't know whether it's projecting well or not. There is on the upper part of the kidney, the parenchyma cortical border or contour is not very homogeneous. I don't know whether it's
kidney is normal.
Kidney is normal. Okay. So in this liver, I can see the liver is cirrhotic. I cannot see any focal liver lesion other than hypoechoic lesion in the right of the liver.
Only slight. I mean, you described it well. You've gone to the diagnosis, but the only recommendation which I'm going to make is that you went to describe it straight away, or it looked like a cirrhotic liver. Mm-hmm. The examiner wants, once they're sitting there, okay, it is very obviously cirrhotic liver, but they want you to describe that it is basically slightly heterogeneous echotexture, the surface is irregular, no obvious lesion, likely to be cirrhotic liver disease. The image on the right bottom of the screen, but that is showing slightly enlarged spleen, basically. Okay, so once that is being described, it's basically being described as cirrhotic liver disease. And as I said in initial presentation, that the patient has some abdominal swelling. So if you can see the bottom left of the image, there is some fluid next to the liver. So some ascites is present. So overall, it is appearance of the cirrhotic liver disease. Now, this patient has presented for the first time with this presentation. We don't know the cause for the cirrhosis. Can you help in coming to diagnosis or making a diagnosis that how we can diagnose this cirrhosis, that what is causing it?
On the basis of ultrasound scan?
Well, I mean, now you know that it's a cirrhotic liver disease, and the clinicians are contacting you that we want to get to the bottom of the diagnosis. How can you help them?
There are different reasons for cirrhosis. The alcoholic cirrhosis, cirrhotic secondary to the fatty steatosis, NASH, and idiopathic as well. Drug induced. There are different reasons for liver cirrhosis. So a good history would really help. And then ultrasound scan. I cannot see anything to suggest on this scan. The only thing we can see is the element of portal hypertension, secondary liver cirrhosis.
Okay, second liver cirrhosis. Now, there is no suggestive history which we can point you to one direction, and they are unsure about the cause. Especially, there is no history of alcohol intake. How would you help them further?
The biopsy can sometimes, non-targeted liver biopsy can help to find out the cause for the liver cirrhosis in this scenario.
This patient has got INR of 3. How would you do the biopsy?
With INR of 3, there are two ways, either to correct it through FFP if that can be corrected, otherwise transjugular.
Very good.
Is another option.
Now, describe the transjugular biopsy. How is it done?
It's done through the jugular vein, interjugular vein, and then the catheter is passed through the IVC.
Good.
And then through IVC, the liver tissue is a transvenous route, so the transvenous route.
Why do we have to do the transjugular biopsy? What are the benefits?
with the percutaneous biopsy, you have to breach the liver capsule. So with the high INR, that potentially causes increase the risk of bleeding in the patient, especially with the high INR. So clotting will be difficult to achieve afterwards.
Very good. Now, I mean, as you said, I mean, clotting will be difficult. Also, I mean, this is a patient with cirrhotic liver disease, but occasionally you also encounter the patients who have some bleeding diathesis. And if they have any liver problems, then again, you can recommend the transtubular biopsy. The reason recommending transtubular biopsy is you're going through the vessel into the liver parenchyma. Unless you have passed a very big needle and breached the liver parenchyma, you are basically just connecting the blood vessel to the liver parenchyma. So these patients, they do not bleed. Okay. The transtubular biopsy normally performed through the right internal jugular access. Once you got the access, one tend to guide the catheters and wires into the right hepatic vein. The reason it is advanced into the right hepatic vein because this is usually the chunkiest part of the liver, and this is the biggest vein. Once over there, once you are scared with the contrast, then you advance the needle and take some samples. Okay. So I'll just show you one more case. It's on a similar theme. This patient has got 38 years old female who presented with upper abdominal pain, previously totally healthy. Selected CT images are presented. Kindly describe the findings.
So through these axial slices of the CT abdomen to the liver and in the portal venous phase, demonstrating quite segmental hypoattenuation of the right lobe of the liver, with quite defined margin. The rest of the liver appears normal. The portal vein, the visualized portal vein, and visualized portal vein appears normal as well. So this is quite subcapsular or peripheral hypoattenuation. This could be. It's very difficult. It's very. The differential in this case could be liver infarction.
Hang on a minute. Let's go to some findings first.
Okay, sorry.
Now, you have described it very well that the visualized portal vein is looking well. You have described that there is a bit of irregular enhancement of the part of the right lobe of the liver. Okay. Once you notice such things, the next thing is, can you see the hepatic vein?
I can see the left, but not the right.
Good. Okay. So the right hepatic vein is not visualized, and what could be the reason it's not visualized?
It could be thrombosis.
Good. Excellent. So that should give you your diagnosis there. So you have described that one hepatic vein has got some thrombosis, is not visualized. That is leading to the altered enhancement of the right lobe of the liver. What's your diagnosis?
Since the rest of the liver appears normal, I wouldn't call it Budd-Chiari.
Well, I mean, it is Budd-Chiari. Budd-Chiari can happen with the selective.
Okay. Sure.
Okay, so that your diagnosis is there. Now, how the radiology can help in the management of such patients?
Intervention.
This is intervention session.
I'm not sure. I mean, whether we can retrieve the clot or thrombectomy from the main hepatic vein or the branch of the hepatic vein.
Okay. Is there any other way as well?
Intravenous thrombolysis?
Well, intravenous thrombolysis can be done, but that is usually not done for the hepatic veins. It's done for the portal veins. Okay. The person, I mean, wanted to, or the reason I was asking this person, basically point towards you some definite management. The patients with blood carry, and the previous patient which I did show you about the portal hypertension, there is a radiological management for these patients as well. Tips. Brilliant. Okay. What do you know about tips?
So it's a shunt between the systemic and portal venous system.
Good.
And that's what I know basically.
Okay. Just to describe you, I mean, if they ask you during the examiner, or if they show you any similar images which are being projected on your screen, TIPS is basically portosystemic shunt. Okay. The way you describe the jugular transjugular biopsy, it is essentially a similar procedure, but in this procedure, with the needle, you tend to get from the systemic vein into the portal vein. Once you have, I mean, as you can see on the image image B in the presentation, which is basically just highlighting the right portal vein, hepatic vein. Then there's an attempt being made to get into the portal vein with a needle puncture. Once the attempt has been made, as shown in the image T, the portal vein is then highlighted, wire is passed into that. The tract is then dilated with a balloon, as has been shown in the image E, and then finally you put a stent across, and that creates a shunt. That lowers the pressure in the portal system. Okay, the patients with the portal hypertension, they tend to have hematemesis, and this is the way basically to relieve the pressure and relieve them of the symptoms. Similar is the situation for the patients with blood carry, and tips can be offered to them. So once you are basically presenting your case, we can also recommend that we can offer tips for such patients. Okay? One more case for you. Now, describe what the procedure has been performed.
So these are fluoroscopic images through the abdomen, I think. There's a pigtail drain with the contrast on the top left, the bottom left image.
Good.
Just trying to establish which organ is involved. Here, it looks like a tubular organ, hollow viscous.
Good. Hollow viscous.
So probably it's the CVD through into the duodenum, or I think there's a catheter has been passed through the hollow viscous into the duodenum.
No, I mean, bowel is not highlighted.
Yeah.
In any of these.
I can't establish which organ has gone through, but
okay. Okay. I mean, the examiners, once they are looking at you, they taking you through, they can just show you the such images as well, and then can ask you to take you through the images shown, and basically come to conclusion that what has happened and why it has happened. Okay. So if you look at these images, this is basically showing you Seldinger technique. Okay. The image on the top left, that is showing a needle access going into a viscous with some contrast. A wire is passed, then it is serially being dilated, and finally catheter is being inserted. If you concentrate onto the bottom right image, it is a hollow viscous, which is on the right side of the abdomen. It's below the ribs. What it could be?
Right side of the abdomen, below the ribs, hollow viscous. Bowel, it can't be bowel. Gallbladder?
Good. It could be either a gallbladder or a right kidney, isn't it?
Yeah.
Okay. So this is the catheter within the gallbladder. As you can see, there's some filling defects. And if you look at it towards the basically periphery of the image, I think you can make out that there's a cystic duct with a filling defect right at its end.
Yeah.
Okay, so this is a cholecystostomy which has been performed. Do you know how the cholecystostomy is performed?
Yeah, normally it's performed under the ultrasound guidance, but you've shown an example of through the fluoroscopic. So it's again the same principle. Patients consented, and then percutaneous Sardinger technique. It's normally done through the transhepatic route for the stabilization of the tube. Also, bile to minimize the bile leakage into the peritoneum as well in the abdominal cavity, for the less irritation of the peritoneum, or to avoid the biliary peritonitis. So again, the principle is the same, Sardinger technique, or the other principle is trocar, single step trocar technique, which is again in some instances it's doable when it's very distended gallbladder and it's very superficial. But again, Sardinger technique is preferred for the safety reason.
Good. The cholecystostomy, there used to be a discussion whether one should be going through the liver or not. Okay. But I mean, there are studies now published that one doesn't need to go through the liver parenchyma. For the safety of the procedure, it is still recommended that you can go through the liver parenchyma if available. On the other hand, if the liver is basically a big thick margin of the liver is between the skin and the gallbladder, you can go directly into the gallbladder. It used to be recommended for the reason because people used to say that there will be bile leak and the risk of biliary peritonitis. Having said that, the studies published have shown that actually that is not true. So this is the same patient basically showing a distended gallbladder. It's a CT, so you cannot see the gallstones very well. And this is just a brief description. Okay, as you said, I mean, it has to go on through. We have to basically take out all the infective material. Okay, so it's the technique is similar as for drainage anywhere else. Okay. I'm just showing you some ultrasound images. Please describe the findings.
So I've got selected ultrasound images from the liver, in which I can see that the liver has a normal contour, but there are multiple dilated intrahepatic bile ducts. And I can see in the lowermost image that what appears to be the common bile duct and appears dilated. I don't have a measure. I think it's 12 millimeters, which would be I take as the above the normal. So basically, we've got multiple intrahepatic biliary dilatation, but I cannot identify a cause on these images.
Good. As you rightly described, this appears to be normal liver parenchyma. There is intra and possibly extrahepatic biliary dilatation. This patient presented with obstructive jaundice. We could not identify the cause. How we can help this patient? What would you be recommending while writing a report for this patient?
So in my normal practice, because I'm worried in a patient with obstructive jaundice, I'd want to find the cause by using an MRCP to start with, because that's the least invasive and also gives us a good clue as to what the underlying anatomy is like. So I'd start with an MRCP, and depending on what that shows, might go ahead with an ARCP or a PTC. But again, that depends on what the MRCP will show.
Good. Absolutely. You described it very well. That will be the normal recommendation route, that you're going to recommend an MRCP. If the patient is fit enough, the patient ideally should go for ERCP to relieve the obstruction and can get the diagnosis. Well, on MRCP, there was no obvious obstructive stone which could be identified, but there was obstruction at the level of the lower common bile duct. Okay. It was not very clear that what exactly is causing that obstruction. ERCP could not be done because patients have had, the RCP could not be done because of the previous gastric surgery. So what would you recommend next?
We could do a percutaneous transhepatic cholangiography, a PTC.
Brilliant. Well done. How do you do that?
So that is done under local anesthetic, and basically what you do is under local anesthetic and ultrasound guidance to identify the peripheral ducts, and then I think you use a Schilber needle, a 22 gauge. You identify the duct, you approach the duct, and then once you're in the duct, you want to check a biliary reflux to make sure you're in the right place, inject a water-soluble contrast dye, and then that basically just delineates all the anatomy.
Very well described. I mean, basically, one tends to get into the one of the dilated ducts, depending upon which one is easily accessible. You can go through the right side or the left side, or if there is only one side obstructed, as we may see from time to time, depending upon the obstructive pathology, then you go for the same side. Once you're into the biliary system, you inject some contrast, and the rest of the procedure is usually completed under fluoroscopy. You delineate the tract, then try to negotiate and get across. Now, the drainage is once you're just basically taking the pressure off by putting a small drain in, but we also tend to put some stents in, as you can see in the slides shown. Are you aware of any difference between the drainage catheters for the biliary tree and for rest of the body?
I think we'll go for a 22 gauge here, and that's the only. I'm not entirely sure.
Okay. No, you don't go for the 22 gauge. It's normally 8 French size. The 22 will be very large for the biliary tree. Okay. The difference between the biliary drainage catheters and the other catheters is that, especially if you have gone across the area of occlusion or stenosis into the bowel, as you can see on these images, this is called internal external drainage catheter. Okay. The reason it is called internal external drainage catheter because it has a set of holes right towards the tip of the catheter, and then it has a set of holes up to about 8 to 10 centimeter. The reason for this is that it is usually connected to the bag outside, but these holes, if once you have got across the obstruction into the bowel, they allow the bile to drain in the bowel as well. On the other hand, if it is really tight or obstructed, then it can drain out into the bag as well. That's how it allows the dual drainage. That's the only difference. If you cannot get across the area of obstruction into the bowel, then normally the usual pigtail catheter is used. Okay? Are you aware of any special precautions or any special measures?
Like with all procedures, obviously we need to make sure the platelet count is not below 150 PTA, PTT. Then these patients need antibiotic prophylaxis as well. And we should have a cannula in place. Sometimes they might require IV midazolam. And post-procedure, I think they can develop pneumobilia and biliary leak.
Okay. Now, is it a low-risk procedure or high-risk procedure?
I think generally it's, from what I know, it's a low-risk procedure.
That's not correct. I mean, it is perceived to be it's a low-risk procedure, but actually it's a fairly high-risk procedure. If you go to the BSIR registry, the peri-procedure mortality is about 26% in 1 month.
Okay.
Okay. The reason usually for that is that such patients are usually fairly poorly. They have multiple comorbidities, and once they are presented with obstructive jaundice, that they are basically succumbing to quite a few other things as well. Okay. You've rightly described about the antibiotic prophylaxis, and you rightly described about the other things. These patients normally then proceed to have some common bile duct stenting done as well, and then the catheter is taken out. Is there any procedure, or is there any step which you can take while performing this drainage procedure to aid in the diagnosis? You
could do a the cholangiogram, I think.
Well, the cholangiogram is basically, you can see the cholangiogram on the screen right now. Once you've injected some dye into the ducts, these are delineated. So cholangiogram is there, but that is not helping any further with the diagnosis. Is there anything which helps in making the diagnosis clear? Okay. The one thing which you can do, and that quite frequently helps in the diagnosis, you can recommend that you can collect the bile for cytology.
Okay.
Okay. So the collected bile that is sent for cytology, and cholangiocarcinomas fairly routinely can be diagnosed from that. Also, if it is not an initial cytology, you are unable to collect any bile or it's undiagnostic, you can do some brush cytology.
Okay.
Do you know how brush cytology is done?
Haven't seen one.
Okay. Well, I mean, in ERCP, they normally perform the brush cytology. It is a very small brush which is then passed on to the common bile duct, which is scraped at the site of constriction or at the site of stenosis or occlusion. And once it has been scraped through that, then once it's retrieved, the whole brush is then cut off and sent for the cytology.
Okay.
Okay. So it's a similar way, instead of going through the ERCP, you can use the PTC as well for the brush cytology. Okay. Let's go to the next case. So you have selected images. Please describe your findings.
So I've got what appears as a non-contrast axial slices through the abdomen, and I can see that there's a hyperattenuation, a brown ovoid lesion arising from the lower pole of the right kidney.
Okay.
I can also see evidence of pelvic calyceal dilatation in the right kidney. The left kidney, when compared to the right, appears smaller, and the right kidney appears slightly distended. Then I've got images of the lower pelvis in which I can see there is density in what I take to be the ureter on the right, because it's lateral to the IVC, and then also adjacent to the lateral margin of the urinary bladder on the right, I can see what appears slightly lobulated density. So I think we've got, from the non-contrast, I'm thinking whether this is calculus, and then which is causing upstream dilatation of the kidney, and because I can see a soft tissue rim around it, which means the ureter is quite distended, and then the lesion arising from the lower pole. Obviously, in my normal practice, I'd want to measure the Hounsfield units. It appears fluid, low attenuation, but then I'm worried whether this could be urine or a simple fluid. It doesn't look to me like it's layering to suggest that there's blood in there.
Good.
But yeah.
So in a nutshell, how would you summarize your case to the examiner?
So in a nutshell, I cannot see any free fluid in the abdomen and pelvis, but I've got a right pelvic calyceal dilatation secondary to a distal right ureteric stone.
Okay.
And then we've got a cystic lesion arising from the inferior pole of the right kidney, but obviously cannot measure the Hounsfield's units, but the characteristics appear quite simple, and there's no fat stranding surrounding it, and it's a solitary lesion. And then there's a size discrepancy between both kidneys as well. The rest of the abdominal organs appear unremarkable, and I cannot see any free air.
Good. So if I say that the left kidney is atrophic, right kidney is the only solitary functioning kidney, it appears to be obstructed from stone in the mid to lower ureter. Some stones have already passed into the urinary bladder. Okay. So this obstructed kidney, now it's under threat.
Yeah.
Would you recommend anything while reporting this examination?
So obviously we need to, the first thing is to relieve the obstruction.
Good.
Because that's the biggest threat to the patient at the moment is from obstructions, and that's the only functioning kidney. So we'd want to relieve the obstruction, for which we've got antegrade, or the options would be antegrade versus retrograde, and then a percutaneous nephrostomy to start with, because we want to decompress that kidney on the right side, and then at the same time we could consider doing a retrograde or antegrade procedure to relieve, to get rid of the calculus. Yeah.
Good. The first thing is, obviously this kidney needs to be relieved of its obstruction. Okay. As you rightly said, it could be antegrade or retrograde. Retrograde ureteric stenting is usually the preferred method to start with, but it all depends on local expertise and also on the patient's status. If the patient is infected, or if the patient is doing poorly or unfit for GA, then probably they cannot do that procedure, and then they would be recommending for the patient's nephrostomy, i.e. percutaneous drainage. Do you see any trouble in doing this procedure for this particular patient?
I think that one thing that I can see is for nephrostomies, you want to go to the posterior calyx of the mid-pole, ideally. And I can see there's this cystic lesion sitting there.
Good.
And then we are unsure whether this is just simple, it doesn't look like entirely a simple cyst, so then we're unsure of the nature of this. So we could do an ultrasound and just first characterize what this is. Okay. But the path of the nephrostomy that I'd ideally want, this would hinder it.
Okay. Now, this patient did have that big cyst, which is not shown in these ultrasound images, but that was well known. Okay. On the ultrasound images, no direct communication between the pelvic calyceal system and the cyst could be seen. You have very rightly said that this cyst is potentially troublesome. The reason it is troublesome, if we get our first needle puncture into the cyst, we cannot move forward till the time the cyst is fully drained itself. Okay, it becomes very difficult to advance the needles. Your comment regarding the posterior calyx in the mid-pole, in my practice, I don't care about those. Wherever I can, I try to get into the renal collecting system. Normally, it's preferred to go for the lower pole. In fact, not the mid-pole. The lower pole is recommended. We should aim for, but it all depends on patient's anatomy, lie of the kidney. You may not have any direct access to the lower pole because the kidney is very toxic. So whichever is easily accessible, you go for that. And yes, nephrostomy is just like any other drainage procedure. Seldinger technique, it's normally performed under fluoroscopic and ultrasound guidance. Ultrasound is there to get your needle into it initially, and then you follow the Seldinger technique to basically deploy a catheter. Okay? Just view this, the images there. Next case for you. Okay? Can you please describe your findings in this particular patient? Patient presented with abdominal pain, ongoing for a few months. For a few weeks.
Okay, so got a post-contrast axial slices through the upper abdomen, in which you can see there is a tube, which I take to be is in the just on the lowermost slice. I can see there's a tubing there anterior to the aorta. I'm trying to think whether this is in a collection that's there, because but within the upper abdomen there is this distended hollow viscus, which I take to be the stomach.
Really? Well,
or whether it's another cystic lesion adjacent to the pancreas, because I cannot identify the pancreas. There is extensive stranding and loculated fluid in the left side of the abdomen, and interposed in that fluid is a high density as well. Then that's an arterial phase study.
It's more or less portovenous phase study.
Okay. So, and then we've got multiple pockets bits of gas as well. So there's a localized perforation from what I can see. The liver and the spleen are enhancing normally, and there's no perinephric collections.
Okay. Now, you rightly pointed out the observations. Just to guide you, the cystic lesion, which you can see in the top two images, you can actually see stomach is collapsed next to it. You see along the anterior border. If you see, you can identify that there is some wall or at least enhancing bowel tissue with some air on one side. And in the second image, that air is basically outside that wall. Would that help you in coming to a conclusion that what it could be?
I'm thinking whether this is a necrotizing pancreatitis. Of air, and we've got a large pseudocyst probably, and then we've got evidence of necrosis, and I can't identify the pancreas, and then I've got a drain which was probably put in because this patient developed these collections.
No, that is an NG tube basically.
Oh, okay.
Okay, NJ tube. In fact, if you see that tube is actually going through the third part of the duodenum, we are seeing the bottom right image. Okay, and would you call it a pseudocyst?
It isn't behaving like a pseudocyst from what I can see.
Okay. The important, the thing which you need to remember is the pseudocysts, they are not basically infected. If you see the bottom left image, you can see some air locules within that cystic collection, and you can also identify a bit of enhancing pancreatic tissue there. Okay. Next to the branch of the sphenomesenteric artery, there is a bit of enhancing tissue, which is essentially a little bit of whatever the pancreas is left. So whenever you see such locules within the cystic area, they are very highly suggestive of an infective collection. Okay, so if you see that, always you need to emphasize in your report or you're talking to the examiner that I can see the air locule is likely to be infected.
Yeah.
Okay. Now, this is a pancreatic collection. How the radiology can help?
The ones I've come across, they usually insert a drain, and then the drain is left in place, and they have follow-up imaging to make sure that until the largest pocket of drain becomes minimal.
Mm-hmm. Okay. What about the drainage? Are there any special considerations for draining the pancreatic abscesses? Okay. Now, are you aware of any CT severity scoring system for the pancreatic collections or drainages?
Yeah, briefly know that there is a CTSI index, and depending on the number of collections and the complexity of the collections, the score goes up.
That is true. That is the CT severity index is there. Okay. Basically, the things which I wanted to put across for you to know and for the other candidates to remember, that there is a CT severity index for the pancreas, which you should be knowing and describing. The radiology assistant, there is a very good article about all these pancreatic collections. It has got a system, pen code system, they call it. I would highly recommend you to go to the article, go through it, read it, and because that can help you in defining or basically making a comprehensive report for the future. Also, with regards to the pancreatic drainages and collections, the thing which I would like to come across to you is to remember and basically to make a comment during your report, or if the examiner asks you, that we tend to put the largest possible drain into the collection. One tend to go retroperitoneum because that is the same space as the pancreas. And also, if these patients do not improve because of this collection, collection drainage, they are likely to need some surgical necrosectomy or surgical drainage, and it helps if the drain has been put through the retroperitoneal space, because that the surgeon then can stay retroperitoneally and can do the necrosectomy and remove all the debris. Okay. Now, I think it's time to go to our next candidate. Thank you very much, candidate 3. Candidate 4, can you hear us? Please, if you can hear us, please raise your hand. Good. I'll just. So you can hear us, candidate 4?
Yeah.
Okay. Thank you for joining us. This is the next case I wanted to show everyone. This is a 74-year-old male who presented with an abdominal pain. Okay. And here's the presentation. A CT has been done. Please describe the findings.
Okay, these are selected images of the abdomen, upper abdomen. The abdominal aorta appears to be aneurysmal, and there appears to be contrast extravasation outside of the aorta.
Where you can see the extravasation? Which image?
In the bottom image.
That is just a normal vessel. It's not extravasation.
Okay. So there's a peripheral rim of calcification, and there's some areas of circulations within the aneurysm.
Okay.
In my routine practice, I will check if it involves the iliac arteries bilaterally and if it extends suprarenally.
Good.
Looking at this aneurysm, it appears to be larger than 5 centimeters.
Good.
And the patient should be considered for aneurysm repair. I would suggest the patient to be discussed in the vascular MDT for consideration of EVA.
Okay. Can you see any warning features in this CT examination?
So it appears to be sort of draping posteriorly. There's discontinued calcification. These are the 2 signs I can see. There's also some fat stranding around the aneurysm on the bottom 2 images on the left-hand side.
Good.
And there's a local area of where there's discontinuity of the calcification. So there's bleeding capillary eruption.
Okay, what does that fat stranding suggest, basically?
So it's the focal area of inflammation and I suppose weakness or outpouching, which means it's an area which may rupture.
Very good. Okay. So this is an abdominal aortic aneurysm. This is very common commonly shown in the examination. When describing an abdominal aortic aneurysm, there are a few points to be considered that how to describe best and basically why to describe it. So first of all, as you very rightly said, it appears to be larger than 5 centimeter. For everyone else, the abdominal aortic aneurysm, if they become larger than 5 centimeter in diameter for a female or 5.5 centimeter for a male, and by diameter conventionally, it is the AP diameter. So if they become larger than this size, then there is increased risk of rupture. And the current vascular society recommendation is once they have approached this size, then they should be considered for the intervention, which could be the surgery or endovascular aortic aneurysm repair. It all depends upon the patient's status and age. And remember that this diameter dimensions are basically for the fusiform aneurysms. While describing, you also need to comment whether this is a secular aneurysm. Secular aneurysms, which they arise from just one side of the wall of the aorta. Secular aneurysms can rupture at much smaller size, even a 2 centimeter or 3 centimeter sacral aneurysm can rupture very easily, because sacral are thought to be due to local infective etiology, and they are very basically prone to rupture. So they are intervened, whatever their size may be. Okay. Also, while describing the aortic aneurysm, you tend to one must mention the diameter of the neck. Neck is the basically appearance of the normal aorta proximal to the aneurysmal sac. We'll also describe its relation to the renal vessels. If it is well below the renal vessels, i.e. at least more than a centimeter, it's called infrarenal. Aneurysm next to the renal vessels is juxtarenal. If it is involving the renal vessels or extending above it, it's called suprarenal. Okay. Length of the neck, as I said, you tend to measure for that. You also tend to mention the how long the aneurysm is, where it's terminating, whether iliac vessels are involved, and the tortuosity, because all this report is helping the surgeons plan for the future. Okay. Also, as I pointed out, and the candidate very rightly said, whether there is any telltale signs or whether there are any warning signs. The local cobwebs or local straining is very telltale sign that this is going to rupture very soon, because it represents some local inflammation or local weakness. The other thing which normally is commented upon is ulcerating plaque, which is shown in the bottom right image. As you can see, there is an intraluminal thrombus within the aneurysmal sac, but some of the contrast has actually started to invade through this thrombus. So this is suggesting a local ulceration within that intraluminal thrombus, and it is basically more pressure onto the aortic wall, and it's impending rupture. Some centers still routinely perform unenhanced images to see if there is any fresh thrombus within thrombus, as you can see in the image up on the bottom, on the upper left corner. And again, if it is suggesting the fresh thrombus is going through that, and there is basically dissection of the wall, then again, these aneurysms are likely to rupture. Okay. Now, this was not highlighted that this is going to be impending rupture. So this is the same patient 2 days later. As you can see, now you can see the extravasation of the contrast. So this aneurysm ruptured and the patient needed emergency surgery. Emergency surgeries have higher risk of mortality and morbidity. Okay. So this slide is just to show you that if you see a ruptured aortic aneurysm, what are the things which you should be looking for, or how they can basically help you in coming to the diagnosis. Okay. I'm briefly showing you so you can read through it, absorb the information, and then we'll go to the next case. Okay. So next case is a 76-year-old male who has presented with the abdominal pain. So candidate 4, only one image, give me the diagnosis.
So this is a selected image of the upper abdomen.
Good.
So there appears to be contrast in the abdominal aorta and the IVC of similar densities.
Good.
Given the similarity in density between the two, I wonder if the patient has an aortocaval fistula.
Brilliant. Absolutely brilliant. You have rightly nailed it, that the amount of the contrast is same in the IVC and aorta. So this is an aortocaval fistula. Okay. This is another image just to show you, demonstrate you that there is an aortic aneurysm. And as you can see, some of the examiners may tend to show this image, the one onto the right of the screen, which is showing a procedure being performed. Contrast has been injected into the aorta. As you can see from the renal arteries becoming highlighted with that contrast. Contrast is pulling into the aortic aneurysm sac, and then you can see the contrast into the IVC as well. Okay, this is one of the classic cases, i.e. having the contrast density same in aorta and IVC. This is the patient, as you can see on these images. the examiners, they can show you these images as well, where you can see the aorta is basically ulcerating into the IVC and the contrast is going into the IVC. Also, as you can see, the contrast stance is similar into the iliac arteries and veins. So this is the high pressure contrast going from the aorta into the venous system and showing an aortic cable fistula. Now, are you aware of any other causes of having similar contrast density between aorta and IVC, especially along the upper abdomen?
Could there be some sort of AV malformation that can cause this?
Good.
Or, AV malformation is the only thing I can think of.
AV malformation is basically another way of fistula, isn't it?
Yeah, fistulization.
Okay, I mean, basically, I've just described here the causes of the early IVC enhancement. There are 4 common causes, especially the proximal IVC. Aortic cable fistula, as we have shown in this case. If there is no aortic cable fistula, one should be thinking about constrictive pericarditis or severe tricuspid stenosis or regurgitation. If the right heart is not functioning very well for any of the reasons, the contrast can basically reflux into the IVC and then can give similar appearance. So these are the 4 differentials normally which we tend to look for. Okay. Now, this patient have had a procedure performed. Can you please describe what procedure has been done?
So they've had they look like they have a aorta bi-iliac stent inserted. So they've had an EVA procedure performed.
Good. So endovascular aortic aneurysm repair, i.e. EVAR, has been performed. The aortic aneurysm sac has been isolated. So once you isolate the high pressure circulation from the low pressure circulation, that normally resolves the problems. Okay. Let's go to the next case. On the similar theme, please describe your findings in these CT images.
So these are selected images in the arterial phase of the abdomen, lower abdomen. So there is an abdominal aneurysm, once again, which extends into the iliac arteries bilaterally. It doesn't appear to extend suprarenally. Both kidneys demonstrate normal enhancements bilaterally. There is a focus of increased attenuation within the in the bottom image on the left. I can see an area of high density within the within the bi-iliac stent area. And I wonder if this patient has actually had an EVA repair and this represents an endoleak.
Good. Well done. So yes, I mean, there are quite a few telltale signs that this patient have had an aortic aneurysm repair. If you see the contrast is well defined, you can see very small metallic struts into that around the contrast. I'm afraid to show that endoleak, I could not window it appropriately to show for the presentation. I'll see how I can improve it further in future. Now, very rightly described that this is an endoleak. How many types of the endoleak are there?
There's 5 types.
Okay. Can you please name them? Which one is one?
I know a few of them. Type 1 is the sort of the landing zone, the proximal distal ends. I think type 2 is basically, it arises from the branches, possibly, branch vessels. Type 3 was a defect within the actual graft or actual EVA. And I can't remember what type 4 is. And type 5 was if it increases in size without any evidence of endoleak.
Good. That's called endotension. Is there any other radiological investigation which can help in further defining that what type of endoleak this one may be?
Can you do direct angiography? Would that help?
in direct angiography, you normally inject just about 15 ml of contrast. That can help, but it may not be very helpful. Is there any other investigation?
Can an ultrasound in the area, the focus of increased density, perhaps
Is
maybe that can...
Is there any special type of ultrasound?
Can you use contrast enhanced ultrasound or?
Absolutely. Brilliant. Okay. So in the vascular and interventional radiology, contrast ultrasound is very helpful, especially the contrast enhanced ultrasound can help you in identifying that from where this endoleak is actually coming. It can at times identify the vessel as well, whether it's coming from inferior mesenteric or one of the lumbar vessels. Okay. So once describing an EVAR in an examination situation, this is a post-EVAR patient. Not only in examination situation, but also while you are reporting in your institution, one need to comment about the patency of the visceral vessels. I mean, as you said that very rightly, that the vessels appear patent, the kidneys look fine. Then you also may need to compare with the previous examination and make a comment whether there is any evidence of graft migration, any evidence of strut fracture, patency of iliac vessels, and endoleak. Once you have described the endoleak, the other thing is normally to compare for this any expansion of the sac size, because if the sacs keep on expanding, this patient definitely needs further intervention to stop that endoleak. Okay, as you rightly described, type 1A is the endoleak from the proximal end, type 1B is from the distal end, type 2 is from the patent vessels, i.e. IMA or lumbar vessels. Type 3 is strut fabric fracture, which is the graft failure, and type 4 is basically porous fabric or endotension, in which you cannot see any obvious leak, but the sacs just continues to expand. Okay. Contrast enhanced ultrasound helps us. So next case for you, again, I mean, I'll be showing you 2 slides to show this case. Concentrate on these slides, and I'll show you the next slides as well.
Okay, these are selected images of the upper abdomen in axial CT arterial phase. The patient appears to have had endovascular repair of the abdominal aorta.
Okay.
The satisfactory appearance of the kidneys. There's some possible classification in the left renal artery, but both kidneys appear to be enhance normally. The celiac axis also appears to be enhancing normally. I cannot see any abnormality in the liver or pancreas in this phase of imaging. The small bowel, I think there's some small bowel in the lower images which appear slightly featureless.
Bowel is normal. Just concentrate on the vessels.
Okay. So, the right renal artery, you have a right retrocaval renal artery which appears to be patent, although slightly lower attenuations within, I think, is artifactual. So in the top right image is an area of increased density within the actual aortic lumen. There's focal areas, and it appears to be in the anterior aspect of the abdominal aorta. I can't see it in any of the other images. This may represent an endoleak in this area.
Outside the aortic stent. This is within the aortic stent.
Okay. So there's high density material. I'll compare to previous imaging to see if this is a new finding or if it was there previously.
It was present since the procedure.
the procedure. Okay, I'll then measure the size of the aorta to see if there's any change in the caliber of the aorta since the
okay, we can come back to this. Have a look at these images. Can you see anything?
Okay, so in the right lower image, I can see part of the stent, which I cannot see on the image on the left. Has the stent migrated inferiorly?
No.
There's also circumferential thickening around the stent, which is the previous the aneurysm sac. I think there's a filling defect in the right common iliac artery.
Okay.
As well, so which may represent thrombus.
Okay. Well, that's just a partial voluming. Okay. So I'll show you one more image, and then we'll come back to these images. Okay. What do you think is happening here?
So this is a direct angiogram, which shows the stent in position and the stent on the, I think, within the SMA. There also appears to be wires or part of the stent which appears to be extending externally. I'm not sure if that's normal or not. I can also see some contrast superior to the branching vessel. I'm not sure if that represents. I'm not sure.
Okay, so if you haven't seen before, probably you'll not guess what's happening here. The reason, and that's all basically serves one purpose of doing all this presentation. Okay, so this is the first slide which I did show you. Basically this is a FEVAR. It is a fenestrated endovascular aortic aneurysm repair. Okay, so this patient had a juxtarenal aortic aneurysm. Okay, so juxtarenal ones are those where the neck length is less than 1 centimeter below the renal arteries. So in order for these patients to have effective procedure, they need to have the stents extended, the covered stent extended above the level of the vessels. Okay, if you extend the covered stent, that can basically, it will cover the opening of all the visceral vessels. So in order to prevent that, or in order to counter that, the custom-made grafts are deployed, which have the fenestrations for the vessels of the both kidneys, sphenomesenteric artery, and the celiac artery. Okay, the image which you see on the top right is basically showing the stent going into the SMA and to the right renal artery. The image, which is both images at the bottom, they are showing the stents within both renal arteries. Okay, so this is a fenestrated EVAR. The other thing which I wanted to show you in the next slide was, if you see, you cannot see the bifurcation of the aortic graft. You cannot see one limb. You can only see one limb going into that is going towards the right common iliac artery. The left common iliac artery, you can see it is not opacifying, and you can see some basically metallic, or which you call a stent, but that is actually a plug. So this is a FEVAR graft. This patient had juxtarenal aortic aneurysm, which was extending up to the aortic bifurcation, but the aortic bifurcation was so small that it could not accommodate both iliac limbs. So this patient had FEVAR at the top and aorto-uni-iliac repair at the bottom. Okay, examiners can show you the images like this one, fluoroscopy, in which we can see all the 4 visceral vessels, i.e. both renal arteries, SMA and celiac artery, they are cannulated. In this image, the stent has already been deployed into the left renal artery, but there are stents in place for the other vessels as well, which will be deployed later on. Okay, so this is the basically VR image of the patient which I showed you earlier. Okay, so fenestrated EVARs are the ones in which we are putting through the stent through each of the visceral vessels. If it is a suprarenal aortic aneurysm. It's usually called a branched EVAR, in which basically it's a floppy construction. The stent extends well above into the thoracic aorta, and then there are fenestrations and small branches which you can individually cannulate and perform the procedure. Okay. I'll just show you one more case before we go for our break. So very quick case. Can you please describe the findings?
Okay, so this is a cavogram, and there appears to be an IVC filter in situ.
Good.
So there also appears to be a filling defect at the level of the IVC filter, and I wonder if this represents retained clots.
Good. Okay. So what procedure is being performed here?
So retrieval of the IVC filter.
Good. So this examination has been performed to retrieve the IVC filter. IVC filter can be retrieved up to how long after the procedure? After it has been deployed?
I think general recommendations, they don't like to keep it in for longer than 6 months.
Good.
But I know that in sort of personal experience that they sometimes are in there for longer, for 12 months or so, and they can still be retrieved.
Good. Okay. You've summarized it very well. I mean, normally it is done within 6 months. Even if some filters, I mean, I have removed a filter which was deployed 3 years ago, but at times the filters, you cannot remove them even after a few weeks because they get embedded into the venous wall. So this was just to show you a case of IVC filter. In this case, there's a clot inside. So basically this filter has served its purpose and it has stopped that clot from going away. We'll not retrieve this filter because it is stopping the clot and will probably stop in the future as it will be left in situ. What are the indications for the IVC filter?
So there's a few indications. If a patient continues to have DVTs despite being on anticoagulation, if the patient is unable to take anticoagulation, and there's some more questionable indications such as major trauma. I know in some trauma centers they put them in due to the increased risk of DVT and thrombotic state.
Good. I mean, basically, if you cannot achieve effective anticoagulation for whatever reason, you can put an IVC filter to prevent against the risk of thromboembolism. Okay. I mean, the reason could be the patient have had recent surgery or is going to have some surgery after major trauma, hemorrhagic stroke, pregnancy, things like that. Okay. Now, there are certain considerations before you, I mean, IVC filter can be deployed through the femoral veins and can be deployed through the jugular access. So these are, we have to identify which vessels are patent. The diameter of the IVC should be less than 32 millimeter because all the filters which are available in the market, they do not cater for any IVC greater than this size. Also, while deploying, I mean, you have to cater for the level of the renal veins because usually deployed below the renal veins. Are you aware of any situation where they can be deployed above the renal veins?
So it can be considered in pregnant patients because of the gravid uterus. And if there's thrombus which is within the renal veins, then sometimes they can put it higher than that.
Very good. Good. Okay, so I'll just have, we'll have a break here for another 5 minutes. Okay. Okay. So, candidate 6, I'm presenting another case for you. Selected CT images are there. Can you please describe your findings?
Okay, these are selected CT axial cuts of the abdomen in the arterial face.
Good.
I can see evidence of atherosclerotic changes in the abdominal aorta, but it's of normal caliber. You can see both kidneys are enhancing well, but I can see a enhancing mass in the right lower kidney medially.
Good.
I cannot see any other abnormality or any other masses. Maybe there is a tiny cortical hypo enhancing area on the other side, but not be an old scar or a cyst. Okay, so in summary, I'd like to further assess this lesion. And mostly it will need histological correlation. The room for, if it's a malignant lesion, there is a room for percutaneous ablation.
Very good. So once you're describing to the examiner, first of all, you need to give your impression that it can be potentially malignant lesion because of its intense enhancement. Okay. Recommending the biopsy and ablation. What sort of ablation you would recommend?
There are different sorts of ablation for this lesion. We can perform cryoablation, and we can also perform RF ablation. It's not a central lesion. There is no big fear about injuring the ureter or the renal vessels.
Good. Absolutely good. So you're describing a renal mass, basically, and whenever you're describing a renal mass, not particular to this case, but if it had been a large renal mass, one must also comment about the lymph nodes, about any obvious thrombus within the renal veins, because that is part of the staging process. So that is just a side, but you have described very well. Well done. As for the other candidates who are listening to us, basically a single solitary small lesions in the kidneys. Currently, the preferred method is to perform ablation as a definitive procedure. The ablation, in my center, it is the cryoablation, but as the candidate rightly said, it could be radiofrequency ablation, it could be microwave ablation. Basically, any thermal ablation will serve the purpose. Previously, we used to have a debate whether such lesions should be biopsied or not, because there was concern regarding the seeding of the tract. But the current practice is even solitary lesions, they should be biopsied to come to the conclusion. This biopsy can be performed at the time of the ablative procedure as well, but this is the current practice. Okay, so again, the similar discussion we had all night, MDT decision to go for the final management of such patients, imaging modality and fresh plotting, and which imaging modality you're going to choose for the biopsy. It all depends on local expertise. One can use the CT. Usually ultrasound is used, coaxial needles, and then also the ablative procedure. Okay. So next case for you, it's a 47 years old patient who presented with sudden onset abdominal pain, and here are some CT images.
Okay, so axial CT images selected of the portovenous phase, showing massive perihepatic collection that's with defect in the segment 7 laterally.
Good.
As well as a large hypodense area underlying this defect. I can see a focus of hyperdensity on the top right image at the liver, at the surface of the lesion, possibly a pseudoaneurysm, and on the top left image there is extravasation continuous with this extravasation on the liver surface. I'd like to convey these findings urgently to the referring team and the IR on call for possibility of embolization.
Good. Now, what's your diagnosis based on this?
It's mostly ruptured tumor, because
very well done.
No,
well done. Okay. This patient is only 37, but yes, the tumors can rapidly grow in size and can rupture. So this is the patient who presented to our A&E, no history of trauma. CT scan was done, extravasation was noted, and as you rightly said, notifying the concerning clinical team and also asking them to contact the interventional radiology. What interventional radiology can do?
We can access the celiac arteries and hepatic arteries and embolize the bleeder.
Good.
Maybe glue or coils.
Good. Okay, this was the ultrasound which was done on the same night the patient presented. Can you describe the findings on this one?
Okay, I can see the mass lesion just cranial to the kidney.
Good.
I think there is also the Morrison's pouch is filled with heterogeneous blood.
Good.
Filled.
So it basically further aids to your diagnosis as this is most likely a ruptured tumor. Okay? Now, good.
It's the late arterial and early tissue phase. I can see extravasation. I can see that the tumor ill-defined. It's a very large tumor as we saw in the CT. I can see patches of abnormal extravasation projected over the center of the tumor blush and maybe medially and infralaterally.
Good. It appears you obviously have some exposure to interventional radiology, the way you're describing everything. But for the other candidates who are watching this presentation and listening to you, I would just briefly describe the reason everyone else, the reason this candidate described that this is the radial access. As you can see, the catheter is coming from the top. So it is radial or brachial access, which is another common method to get into one of the mesenteric vessels. If the catheter has been coming from the below, then would have been femoral access. This is the selective angiogram with vesical catheters and then microcatheter into the hepatic artery. You can see blush. This is usually called a tumoral blush. And the candidate 6 described that he can see the extravasation. I'll point it out for you if you haven't seen beforehand. These are the areas which are showing some extravasation. This is basically contrast outside the vessels or outside the normal parenchyma. So this is the extravasation, and it is showing the excellent view of basically a ruptured tumor. As we discussed earlier, and Kennedy rightly pointed out, we can help these patients by embolizing. So this is the next image. We have performed a super selective angiogram. Can you see the point of bleeding here?
Yes, I think it's in segment 6. Or
good. Okay, so once over there, we did then perform embolization. Embolization was performed with the particles. This is the selective angiogram. After the embolization, as you can see, there is lack of arterial flow into that white lobe of the liver, leading to cessation of the bleeding. Very well done. You really nailed this case. Okay. So also for the other candidates, this is the case I showed you. This was a ruptured tumor. Okay. But similar presentations, you can see with liver laceration or splenic laceration, renal eversion or renal lacerations, or all very large renal angiomyolipomas, which can be presented to you in the examination. And while, it can be as a long case or as a discussion, as basically viva case. If it is a long case, then you basically, in all such scenarios, you describe this and you recommend that the interventional radiology can help by performing the embolization. And that will, I'm sure, get you some extra points. Okay. So next case for you. Can you describe the findings?
Okay, these are corresponding dynamic CT and MR of the liver.
Good.
Early arterial enhancement and late washout. These are typical for an HC of segment maybe 4A.
Good. Absolutely right. So this is an HCC, typical basically features. Now, the previous patient which I showed you, that was also a HCC, previously undiagnosed, presented with a rupture. Patient had a hepatectomy and is doing very well these days. And this patient is basically, as you can, the only other finding which I would have liked you to comment upon is about the irregularity of the liver, especially on the CT images. So that is basically pointing out background cirrhotic liver disease with development of HCC. It's again very common finding. Can we help HCC patients in their therapy?
Yes, of course. We are cornerstone, IR is cornerstone in treating HCC. We can do a lot of local regional therapies in form of maybe embolization, STACE, or ablations like microwave, RF, and...
Good. Very good. So, I mean, just when you are describing this case or writing up in your long case, you can, first of all, once you have described it, the interventional radiology can help in getting to the absolute diagnosis. And then, yes, as you rightly said, we can recommend TACE or CERT, and then or any more form of the ablation as well. Okay. Next case for you. By the way, I got similar case in my exam. So, is the case for you to describe and basically present your findings?
All right. So. This is arterial phase selected cuts of the abdomen. I can see non-enhancement of the left kidney.
Good.
As well as the lower splenic pole. I suspect aortic dissection if this is not in setting of trauma or maybe embolism, systemic embolism.
I would recommend you to go through the findings again. You have described 2 findings, but there are more findings.
All right.
You come to know what's the diagnosis there.
Yeah. I can see also the liver is it's homogeneous, but yet the right in the left iliac, common iliac artery.
Good. And
checking the other vessel, the SMA looks fine.
No.
No, yeah, the celiac axis has a saddle thrombus over the origin of the hepatic splenic arteries.
Good. Okay. So this is, once you have described these findings, that there is embolus there is basically infarction in the kidney and spleen, what are you going to recommend further?
I'm going to, of course, check the rest of the scan and echo, Doppler.
Good. So for all the other candidates, once you have identified that there is some thromboembolic has happened, as in this case, the kidney is infarcted, there is a selective infarction of the spleen. Always recommend that patient should have an echo to see if there is any left cardiac thrombus or any thrombogenic phenomena over there. Okay. Now, the concerning team has contacted you that can you do thrombolysis to preserve the kidney? Can you do that?
I can't see a contraindication to do it if there is no other systemic contraindication to thrombolysis. We can do catheter-directed thrombolysis. We have patent right iliac axis as far as this image is concerned.
Good. Now, that was basically a spin-off question. You know, the kidney, its warm ischemia time is only half an hour.
Mm-hmm.
Okay? So if the kidney has been ischemic for half an hour while the patient is still warm, that's what we say, then it's not retrievable. This kidney cannot be now retrieved. Okay? Normally the patient would have presented to you with a few hours history. So you can decline that request. But if the clinical team asks you, okay, there is some thrombus into the celiac artery, we think the patient's liver functions may be compromised, can you do the thrombolysis over there? Or let's say, in this case, it's a celiac artery, but had this been the SMA, and they think the small bowel is threatened and they want you to thrombolyze the SMA, what would be your answer?
I suggest first thrombectomy. If it fails, we might add thrombolysis.
No. I mean, you don't do a thrombectomy first, okay? The reason is, especially if the surgical thrombectomy has been done, you cannot do thrombolysis afterwards. It's one of the absolute contraindications. If the recent surgery has been performed, you cannot start TPA because the patient will start bleeding. Okay? So once we are basically assessing the patients for thrombolysis, we are looking for any contraindications as well. The mesenteric vessels, especially the SMA, I mean, celiac artery, if it becomes completely blocked, you can leave it. No need to thrombolyze it because the liver, okay, there may be a small hit on its function, but it has a dual supply. If SMA is fine, it will get its supply from the portal vein and it will recover. Stomach is full of dual supply. It gets supplies from anywhere and it will basically live through. SMA, if it is blocked and the small bowel is threatened or small bowel is ischemic, then you will need surgical embolectomy. Okay. The reason for that is the results for the chemical thrombolysis for the SMA are not very good, and the patient is likely to get more. Basically, the small bowel is likely to get more damage if you delay it. So that's what you can basically ask the clinicians. No, we are not going to do that. Okay. Now, next patient, an 87-year-old female. She has presented with the leg pain and selected CT images are there. I'll show you two slides. This is the first slide.
Okay, so this is aorto iliac angiogram. I can see tight stenosis of the right external iliac artery, as well as, of course, advanced atherosclerotic changes in the abdominal aorta. It is also a filling defect, might be thrombus in the right common iliac artery.
Okay, good.
The contralateral side is relatively better.
Okay. Are there any other additional findings?
Yes, there is. I think fem bypass from.
Good. Bypass graft.
Yes.
For the candidates, for the other candidates, can you see my arrow there? Can you see my arrow? Candidate 6?
Yes, I can see it. Yes.
Okay, so if you can see, the others are able to see as well. So just to show everyone, this is the bypass graft which candidate 6 was referring to. It's not fem-fem, it's basically going from the iliac to the femoral artery. And there's the next images. Okay, so what you can see here.
Okay, I can see total occlusion of the right common femoral artery.
Good.
I can see, and of course the SFA is not filling either.
Good.
Only some small branches of the laterals, maybe the profunda, is filling in intramuscular branches.
Okay.
I'd like to assess the runoff.
Well, I mean, basically, the diagnosis is there. You made a comment about the graft, that you can see a graft. Any further comment about the filling of the graft?
Totally occluded.
Good. Okay. So you can see that there is a graft. It's not basically opacifying with any contrast. So this patient have had long-standing iliac artery occlusion. In order to save the limb, previously have had a iliac to femoral bypass surgery was performed, and she has now presented with occluded graft, which is threatening her right lower limb. How can you help this patient?
So depending on how fresh, this type of graft should be under surveillance. If it's fresh, we can perform thrombectomy plus or minus thrombolysis. If it's not, we can perform angioplasty and maybe restenting. But given the very long segment, I'd also, of course, involve these surgeons in the discussion because he might get revision for the surgery.
Okay.
Might be the best option.
I mean, obviously this patient has got poor vessels. She's old. She's still a smoker, and there is an occluded graft. As we discussed in the previous case, you don't do a thrombectomy and thrombolysis. It has to be thrombolysis. If failed, then thrombectomy. Okay, so that should be the order of the sequence of the things. Now, this patient is having, as I said, iliac to femoral bypass graft. How would you approach it?
Okay, I can approach retrograde left common femoral puncture. This would be the safe setting. I think we have enough distance to maneuver from contralateral retrograde puncture. And I can see the bifurcation is patent. The iliac is patent too, if there is any room for up and over approach.
Well, I mean, the right side is occluded.
Yeah.
So you cannot go through the right side at all.
Okay,
It's the wrong occlusion. That's how bypass has been done.
Yes, I assess, make sure that the left common femoral artery is patent, and this is my first choice.
Okay. Well, I mean, your reasoning is sound, but just to make a comment, if you go through the left side, which is, by the way, patent, the graft has been done from the external iliac. So angulation will be very acute to negotiate. Okay. So I did this case, through the brachial access. Okay. Now, before I show you the other images, just wanted to emphasize, as with the previous case and this case, that if there is thromboembolism or just a local thrombotic process, you need to see that whether the patient has got AF, dehydration, or if there is any undiagnosed malignancy. If it's just a first presentation, you recommend thrombolysis. And also, you at the same time, you assess for is there any risk for thrombolysis. As I mentioned, that if the patient have a recent surgery in the last 6 months, then you don't perform the thrombolysis. Okay?
All right.
Or if the patient have had stroke, especially the hemorrhagic stroke in the recent past, any history of upper GI or lower GI bleed within the last 6 weeks, these are the risk factors for the thrombolysis. Because you're injecting the patient with tissue plasminogen activator. If you give those, it starts to bleed, and the patient can get a lot of complications from those. Okay. There are 3 different types of thrombolysis of thrombectomy. Surgical is thrombectomy. Chemical thrombolysis, when we are giving the TPA, just the catheter through the catheter guidance, or it can be mechanical. We have different devices available which can break the clot and suck at the same. So that is the mechanical thrombectomy. Okay. So this patient, just to basically show you the images, brachial access. As you can see, what I was describing, the acute angulation. In the image A, if we had access through the left common femoral artery, it would have been very difficult to negotiate that acute angulation and then go across into the right side.
Yes, agreed, yes.
Okay, so in image B, that has been negotiated from the brachial access. The catheter has reached the occlusion, reached the profunda femoral artery, which was the only patent femoral artery. You can see that the image C is basically after some mechanical thrombectomy has been performed, and that is showing some open vessels. So after that, it was commenced. The chemical thrombolysis was commenced. Okay.
All right.
Okay. Now, thrombolysis images. So, and these are the images shown. Okay, I think we'll now go to the next candidate. Enough cases for you. I've given you enough billing. You've done really well there. Okay.
I said we will continue with him.
Okay.
Because because of some other reasons, they cannot. So we'll continue with candidate 6.
Oh, who are you? Who are candidate 6? Okay, candidate 6.
Are you happy with that?
Yes, I'd love to.
Okay, please carry on. Well done.
Thank you. So, next case for you. Please describe the findings.
Okay, so this is a plain erect AP chest radiograph of a skeletally mature patient showing markedly widened mediastinum, as well as haziness of the left mediastinal border. In a setting of acute patient and the setting of an IR session, I'm suspecting dissecting aortic dissection.
Good. Well done. Is there any specific name to this? This sign?
I don't have a specific name, to be honest.
You know can you see my arrow?
Yes.
So it's a double crescent sign. Okay? You can see two foci of calcification next to each other. That is very highly indicative of aortic dissection. Okay? Would you recommend any further imaging?
Of course, I recommend aortogram.
Okay? So I'm going to show you two images. Describe the findings. Okay?
Please. So I can see intimal flap in the descending thoracic aorta.
Good.
Actually, it's involving the arch too.
Good.
On this image, I cannot see involvement of the ascending aorta.
Okay, this was basically the previous scan for the same patient. Now, how would you describe the findings?
So the intimal flap is continuous all through the abdominal aorta down to the left common iliac artery. I can see opacification of the major vessels of the abdomen. The celiac is opacifying mainly through the false lumen. I can see both kidneys are enhancing, but I cannot see the main renal arteries on these cuts. I can see the SMA is opacifying too.
Good. So basically, whenever you are describing the aortic dissection, you need to make a comment from where it is commencing. As I showed you in the first slide, where do you think it is commencing?
I think it's commencing from the junction between the ascending aorta and the arch.
Good. So what type of dissection this is?
Stanford A.
Good. Okay. So for the other candidates, when the examiners are asking you, they are asking basically, they're looking forward to see whether you can classify it. There are two different types of classification. One is Stanford, the other one is DeBakey. Basically, they overlap. It's just in terms of risk stratifying. I mean, I tend to follow the Stanford A, which as the candidate described. If anything is basically, if the dissection is commencing proximal to the left subclavian artery origin, it is Stanford A. If it is beyond the left subclavian, it's Stanford B. Okay, a Stanford A type are likely to lead to more complications and quick death because of the involvement of the coronary vessels. Stanford B, they can be managed really conservatively. Also, once you are describing it, you need to make the comment about the true lumen, false lumen, up till what extent the dissection is extending to. In this case, for example, it was extending up to the iliac vessels, which is supplied by the true lumen, which is supplied by the false lumen, and whether any compromise of the visceral vessels. So that should be your consideration when describing it to the examiners. Okay, this is the CT which was performed at the time of the chest X-ray, as is showing that it is ruptured. This led to, unfortunately, to the death of the patient. Okay. Next case, please describe the findings.
These are selected ultrasound images of the right and left testicles.
Good.
Dilated tortuous structures, mostly varicocele.
Good.
Bilateral.
Good.
I'd like to confirm by color Doppler and measure the veins and assess the patient for reflux or non-reflux on Valsalva.
Well done. Absolutely. You nailed it again. So basically, we need to make the size and look for the reflux. So why we need to look for the reflux?
Because reflux in varicocele tends to be at high risk of progression, and they are amenable for endovascular treatment.
Okay, that is one finding. If it is non-refluxing, is it of any concern?
Maybe especially if it's isolated on the right side, I'd be concerned of an obstruction of the renal or the IVC or the connection.
So that is basically differentiating features. You know, the usual teaching is that once you see a varicocele, always scan the kidney, especially the left kidney, because especially the varicocele are common on the left side. Reflux basically points out to if these are refluxing, i.e. on the Valsalva maneuver, there is a reflux into them, it means it's communicating directly with the IVC. So unlikely that it is getting obstruction because of any malignancy in the proximal course. So reflux is actually a good sign. It is reassuring. On the other hand, if it's a non-refluxing, then it is usually an external mechanical obstruction to the flow, and that points out that there's some sort of malignancies involved. Okay, so you've described it very well. The only other things which I wanted to point out, as you said, the diameter. Palpable varicocele is 5 to 6 millimeter. On the ultrasound, it's usually 4 millimeter. Then basically, these patients are likely to be needing some intervention. We perform the varicocele embolization, which can be done transfemoral route or transjugular approach. These days, we tend to combine sclerotherapy with the coils to give the long-lasting results. The examiner can show you just the testicular images, or they can show you the images like this one. Okay? So what do you think, what can you see? How would you describe this examination?
Okay, so from left to right, the first image is unsubtracted right spermatic venogram. Good. I can see reflux down to the inguinal region, into the scrotum. Of course, it's not into the field of view. And the middle image is the DSA or DSV.
Yeah.
The last image is pointing also the right spermatic vein.
Okay. Once the examiner shows you such images, then they can also ask you about the venous anatomy, i.e. testicular or spermatic venous anatomy. So where does the right spermatic vein drain into the IVC?
It's usually just below the right renal vein.
And where does the left one drain?
Left one into the left renal vein.
Good. So, it's always easier to get into the left side because it is always draining into the left renal vein, and it can be easily cannulated from there. On the other hand, right one is problematic because it can have a variable course. It can drain into the right renal vein as well, but more commonly it drains into the IVC directly, and it can become difficult to cannulate. Okay. Next case for you. Can you please describe this examination and findings?
Right, so this is a left renal angiogram via femoral approach. I'm searching for abnormalities. There is also a catheter, another catheter in place. It's mostly extravascular.
Good.
Assume might be a double J stent.
Very good. It's a double J stent here.
So regarding the angiogram, I can see a small pseudoaneurysm in the lower renal port.
Brilliant. Again, you nailed it. Very well done. Okay. So for other candidates, this is the abnormality. This is a small pseudoaneurysm. This is a patient who have had a PCNL procedure performed. Following procedure, he was having continuous hematuria, and as you can see, there is a small pseudoaneurysm. How we can help this patient? This is, by the way, selective angiogram or super selective angiogram showing that pseudoaneurysm.
Yes, we can coil this. It's an in the artery. We can coil it.
Good. So we can basically do some coil embolization for such pseudoaneurysms. Okay. So this is the coil embolization has been performed and bleeding has been stopped. Next case.
Okay. So these are selected unenhanced CT images of the upper abdomen. I can see abnormal calcifications within the pancreas. You can see a hypodense lesion. I assume in the posterior to the pancreatic body and tail, in the region of the splenic vessels.
Good.
Okay, I think this might be one of complications of recurrent pancreatitis, to get a splenic artery aneurysm.
Very well done. Okay, so there is the post-contrast CT angio, which is demonstrating that splenic artery aneurysm. For all the other candidates who are observing this, basically once described that there is calcification within pancreas, which is basically pointing out to chronic pancreatitis. Once you identify the chronic pancreatitis, you should be looking for different complications, whether the patient has got cyst, which is one of the common complications, or aneurysm. Some visceral vessels basically goes very close to the pancreas, especially the splenic artery, and splenic artery aneurysm is very well-known complication of the chronic pancreatitis. How do we treat them?
Okay, it can be tricky to call this huge aneurysm, but the classic treatment for a true aneurysm is coiling. Although there are other treatments like maybe use a covered stent or a stent or balloon-assisted coiling or a flow diverter.
Good. I mean, what size aneurysm would need treating?
So the cut-off value I know is 2 centimeters.
2 or 2.5. I mean, it depends which center you are. Normally, in my center, if it is more than 2.5 centimeter, we tend to treat them. Okay, so there are just some angiographic images. These are the CT images reconstructed showing that pseudoaneurysm. These are the procedure images, basically selective cannulation of the splenic artery, demonstrating pseudoaneurysm. And then this is a technique which is called basically shutting down the front and back toes. As you can see, the coils have been deployed distal to aneurysm and proximal to aneurysm. And in the final image, you cannot see any contrast filling of the aneurysm. Okay, so shutting the front and back toe, if the examiner asks you, that is the way to describe this. Okay, similar theme. Describe the findings and similar theme. So, what are the findings which you can see in this CT examination?
Okay, I can see abnormal enhancing rounded structures surrounded by hematoma and fat stranding in the anterior abdominal on the left.
Good.
I'm trying to guess the origin of this vessel, but maybe it's an injured intraepigastric artery.
Good. So a needle biopsy was being performed that has injured the inferior epigastric artery. Okay. And this is the inferior epigastric artery pseudoaneurysm. Okay. What are in addition to the embolizing, are there any other methods of treating such pseudoaneurysms?
Yes, we can use thrombin injection.
Good. Very good. Is there any other method?
It can be called like maybe glue, maybe.
Yeah. So, in addition to the the coils and thrombin, still, especially in case of the common femoral artery pseudoaneurysms, ultrasound-guided compression. You can also employ that. If you can see the neck of the pseudoaneurysm on ultrasound, direct compression can be applied for about 6 to 10 minutes and see if that clots within the aneurysm and that treats it. Otherwise, image-guided thrombin injection or embolization. For example, this inferior epigastric artery aneurysm, we had to treat it with the coil embolization because the thrombin injection failed in this patient. Okay, so key points are, ultrasound, you can make a diagnosis, yin-yang sign, you can see swirling blood within the pseudoaneurysm. CT is usually typical, radiological management can include compression, trauma injection, or embolization. Quick, next case.
So these are sagittal T2 weighted images of female pelvis showing enlarged fibroid uterus.
Good.
There are multiple hypointense, well-defined focal lesions within the fibroid, within the uterus. There is one of them exhibits high signal in the posterior fundus.
Good.
Mostly degenerated.
Good. Can we help this patient?
Yes, we can, especially if it exerts post-contrast enhancement, and if the primary symptom is menorrhagia. These are the most beneficial. Most patients will benefit from that.
I mean, these patients normally present with menorrhagia. That's usually the symptoms, or dysmenorrhea at times. Some of them present with the infertility as well. Okay, multiple uterine fibroids, uterus preserving surgery can be performed, but is there any radiological management?
It's uterine artery embolization.
Good. What we normally inject in the uterine artery embolization?
Particles, maybe embospheres or PVA particles.
Good. Usually it's embospheres or PVA particles because they are semi-permanent, and that's what leads to necrosis. So this is the image representation of the uterine artery embolization. It can be performed through the one-side access or both sides. We may have to get access from the femoral arteries. Up and over approach is used to selectively cannulate the uterine arteries, and then those are embolized. Okay? We have, in embolization, if you're going on the theme of the embolization, as we previously said, they can still show you pelvic trauma cases. The patient is having bleeding from the pelvic fractures. Again, they can be embolized with the particles. They can be embolized with the coils. They can be embolized with some fibrin as well. Okay.
All right.
Let's skip this one. Now, describe this one. What are your findings?
Okay, I can see a guide wire inserted, projected over the IVC, right atrium SVC, and it's coiled up.
Good.
Over the right anterior chest wall. I can also see a stent projected. It looks like a strut for stent, maybe it's not. Okay. There is a tubular.
Good. It's a tubular structure.
Tubular structure passing from the atrium, crossing the SPC and up to the right brachiocephalic vein. I think this is SPC stenting.
No.
Okay. Maybe.
Okay. Now, such cases are fairly common. Okay. Now, this is basically showing that this is a broken catheter. Okay. This patient was, the renal physician was performing catheter exchange for the dialysis catheter, and this catheter got broken. Okay.
Okay.
Such cases have been shown where a broken catheter or a broken wire has been lodged into the right atrium, SVC. At times, the broken wires, especially the fine wires, they have been shown to be lodged into the pulmonary artery bifurcation, and then the examiners throw you the candidates away that what is there. In this case, I have left the wire in to give you the guidance, but it could have been easily without any wire, just a broken catheter.
Yeah.
Okay? So you have to describe the findings, and is there any management for these patients?
Yes, of course, it can be retrieved because it will be thrombogenic, and maybe the reason for exchange was infection, so it needs to be removed. We can snare it from the from the right.
Good. So those candidates who are listening to us who don't have exposure to interventional radiology, basically such broken catheters or wires, they can be snared out. Okay. So if the examiner shows you any such case, you can always recommend that the interventional radiology to be contacted, because these things can be snared. If you're not familiar with the procedure of the snaring, snare looks like as they shown on the image on the left. It is basically advanced next to the broken catheter or wire. Then it is wrapped around it. As you advance the catheter, it catches it. And as you can see in the image on the right, that it has caught this broken catheter and it has been retrieved. So all such broken catheters can be retrieved. Okay. Not only the broken wires, there could be some non-target embolization of the coils or the plugs, which you may see have basically flown into any of the pulmonary artery branches, atrium, even right ventricle. The images can be shown to you during the examination, and then you can ask what are the findings and how the radiology can help. Okay. Okay. This is our final case. Okay. Please describe the findings.
Okay, so this is axial and coronal, axial and coronal, I think MRA for the abdominal aorta at the level of renal arteries.
Good.
I can see tight stenosis of the left renal artery origin.
Good. Would you treat this?
Yes, it's very tight stenosis. If it's symptomatic in the form of hypertension or so, then I would angioplasty this stenosis. If it's in the FMD entity in a young patient, if it's an old patient, stenting gives better results.
So the need to differentiate is whether it's ostial or along the length. Okay. If it is ostial, which this is the case, what is the likely etiology? Is it FMD or atherosclerotic?
Atherosclerotic.
Good. So, once you're making comment about the renal artery stenosis, please also make a comment whether it's ostial or it's along the length. Then you can differentiate FMD or atherosclerotic. In terms of hypertension, okay, would treating it treat the hypertension?
May improve it. It may decrease the possibility of having flash pulmonary edema.
Okay. There has been a big trial. If you go through the Astral trials and things like that, it has shown that treating the renal artery stenosis does not help with the hypertension. Okay. Renal artery stenting used to be very big, but the trial was published back in, I believe, 2007. Okay. Ever since it has declined. Now there are only very few indications for the renal artery stenting. Okay. Those indications are basically if the patient is developing flash pulmonary edema, okay, because of the renal artery stenosis, or if it is a single kidney and its artery has become stenotic, or highly multi-resistant, drug-resistant renal hypertension, i.e. more than 4 drugs. Even in that case, they say that it stops the progression of the further hypertension, but it does not treat it. So renal artery stenosis, these are now treated only in very selected indications. Okay, so another subject to read. I'll show you now just a few things for the interest. Okay, what do you see here?
I see a vertebral collapse, lower dorsal.
Yeah, does interventional radiology help here?
Yes, we can do vertebroplasty, cementoplasty. Yes, vertebroplasty.
What is this procedure?
It's vertebroplasty.
And this one?
Kyphoplasty, it's written.
Yeah, it's written on it. It's basically for the other candidates. The difference between the vertebroplasty and the kyphoplasty is in the vertebroplasty only a cement is injected to stabilize the fracture fragments. In the kyphoplasty, it's usually the vertebra which has collapsed. It is elevated with a balloon and an attempt is made to restore its height, and then the cement is injected. So this is the kyphoplasty with the balloon inflated. What can you see here?
I can see an AVM in the upper limb.
Good. Extremely unlikely that examiners will show you such case. Basically, AVM vascular malformations are can be high flow or low flow. This one is high flow. They can show you some MR images, although extremely unlikely. It's very highly specialized stuff. Okay. Ultrasound images can be shown. This is high flow AVM. Okay. So vascular malformation, they divide high flow, low flow. It can be mixed as well. Lymphatic malformations and venous malformations are low flow ones. Okay.
Right.
What's happening here?
It's an RF Levine needle ablation for the.
You're seeing that. So the candidates who are listening to us, this is basically a radiofrequency ablation needle which has been popped into the liver to ablate a metastasis. Some examiners have shown such images to ask the candidates if they know what's happening. Okay. Now this is the final image which I tend to show you my candidates. You know, at the start of the presentation, I said the mind does not see. The eyes do not see, which the mind doesn't know. Okay. This image is only showing some dolphins there. If you're seeing anything other than dolphin, then you are seeing something you don't know. Okay? Count the dolphins, and yes, good luck for your examination. Okay? And please do give us your feedback. And if you want to include or exclude any cases for the future, please do give us your feedback and write about that. We will try to help you in future in showing some cases, especially if any interesting cases you want to be shown. Okay? Thank you very much. Goodbye, everyone, and good night.
Thank you very much. It was